That's definitely Good morning and welcome to the January 31st, 2024 Yakima County Board of Health meeting. Can we roll call, please? Or not? Is everybody here?
Yeah, everyone that's going to be here. We have Commissioner McKinney is going to be attending virtually.
Thank you.
And then Edie Dibble will not be here. I think that's it. Yeah.
Wonderful. Then we'll move into introductions of guests and guests.
Okay, so we have a new board member, our tribal representative, Ms. Catherine Saluskin. Saluskin. And I'll let her introduce herself.
Good morning, my name is Catherine Saluskin. I'm representing the Confederated Tribes and Bands of the Yakima Nation. I am the Tribal Health Officer, Deputy Director. My background is in behavioral health, but I got promoted and yay, here I am.
Well, we welcome you. Glad to have you with us.
And then we also have a new staff member, and I'll let Sean introduce the staff member.
Yes, good morning, everybody. Noe, Vargas Fuentes.
Vargas Fuentes,
Yes,
yeah.
yeah, I always mix them up.
No worries.
Noe, everybody, he's our new environmental health specialist. He joined us at the beginning of January, if you want to tell us a little bit about it.
Yeah, so I'm a recent graduate from the University of Washington. Recently I was in fisheries conservation, but when I moved back to Yakima, I was looking for something to help serve my community, and this is one of the best positions that I could find, and I'm loving it so far and super excited to be here.
Well, thank you. Noe. It's good to have you on board. Anyone else?
Nope, and Kate is our environmental health manager. We've introduced her before, but she's in here because she was involved in the Group B drinking water or ordinance that we'll be talking about later. So she's here to answer any questions that people might have.
Wonderful. Good to see you again.
Yeah, good to see you as well. Thank you.
You're welcome. Next on the, agenda is executive session. We're going to go into executive session for up to 30 minutes to discuss legal counsel matters relating to agency enforcement actions and potential litigation. So let's do that now. All right, welcome back. The next on the agenda is a public comment. Mr. Ibach, do we have anyone online or in?
I'm not receiving the public comments.
Right, thank you. We do have a guest today. Would you like to please stand and identify yourself?
Hi, I apologize for my tardiness this morning. My name is Marissa. I'm a PNWU student. No comment, just here to listen and learn.
Thank you. Welcome, Marissa. All right. Then we will move into consent agenda. So all items listed below are considered routine by the health board and will be enacted by one motion. There will be no further discussion on these items unless a board member requests, in which event the item will be moved from the consent agenda and considered in its normal sequence on the agenda. Does anyone on the board desire to remove an item from the consent agenda? Mr. Idle, would you read that please then?
December 6th, 2023, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in November 2023 in the amount of $795,657.32. Payment of accounts payable and payroll issued in December 2023 in the amount of $814,051.85.
Thank you. Do we have a motion to approve the consent agenda?
Motion to approve.
Thank you.
I'll second that.
Thank you. So we have a motion and a second to approve the consent agenda as presented. All those in favor, please say aye.
Aye.
Any opposed? Motion passes. Thank you very much. Now we're moving down to the spotlight today, which is the Yakima Health District Year in Review. And Lillian Bravo is going to. There you are. I don't want to show you here. I'm looking. Welcome, Lillian. Go ahead, please.
Yeah, thank you, everyone. Good morning. So today we'll be reviewing 2023. We'll be reviewing some of the highlights of the last year and all the work that the team at the Yakima Health District has been doing. So to begin with, we'll start going over some of the highlights, looking at using the framework of the YHD strategic goals to start reviewing. And to remind everyone that our strategic goals on slide 2 are to deliver mandated services, develop a network of community partners, and increase the effectiveness and efficiencies of district services. After I go over some of the highlights using our goals, then we'll go into some specific cities just to highlight some of the things that have been going on there. So on the next slide, we'll start with strengthening mandated services. As a reminder to everyone, mandated services refers to services that local health departments have to, by law, provide to their communities. And those end up being services related to communicable disease, environmental health, as well as vital records. So some of those highlights related to those areas would be our nursing team managing several different outbreaks over the last year, including 1 flu, 6 norovirus, and while at the same time managing an ongoing syphilis and Shigella outbreak. And during this time, the Yakima Health District was selected to pilot rapid syphilis testing out in the field in partnership with the Washington State Department of Health. That was a critical asset and resource to our community because early testing and detection and early treatment is essential in any outbreak response. At the same time, our team, the nursing team, has been managing 2 tuberculosis patients. And for those that are familiar with many of the tuberculosis patients, that ends up being quite a bit of complicated care, and can also take lots of resources because it's not just the medical care, but also making sure that people have the resources that they need to continue their care over a long period of time. And then look, in terms of vital records, our front desk team has been providing not only just great customer service, but they actually produce quite a bit of output with 6,500 birth certificates and 66 death certificates provided over the last year. And just as a reminder, that's not related to the deaths or births that are seen in the community, but rather the certificates that are asked for. And the same team provided over 10,000 food handler cards for those that are wanting to work within the food industry. So moving on to our next goal, increasing community partnerships, is some of those highlights would be distributing over 1 million pieces of personal protective equipment across the county. That again includes over 800,000 masks, 160,000 gloves, and over 48 hospital beds. That was a big effort on our emergency department team to be able to provide those out to different community-based organizations and medical facilities as well. Also through emergency management, we were able to assist with contaminated water system response, specifically in Terrace Heights and Zillah. And that looked like helping with communications, having an environmental health team available to provide consulting, and making sure that we were able to work in tandem with these communities to make sure we can get water to these residents as soon as possible. And then finally, also wanting to highlight the partnership that we've talked about in terms of receiving over $850,000 in legislative funding specifically for the Lower Valley to make sure that we can provide free testing and provide water systems to those that are eligible, specifically within the Guama area. So again, a huge asset to be able to bring almost $1 million in resources to the Lower Valley for, again, clean water. The next strategic goal is to increase efficiencies and effectiveness. And again, that's something that's part of each and every department to make sure that we can continue to find ways to, again, be efficient and effective to ultimately better serve our community. In that spirit, we wanted to highlight the fact that we completed not one, but 2 clean audits over the last year, which is a great feat for our accounting team. And I did want to point out that that is one of the, that we are, I think, if not the only, one of the only health departments that were able to successfully do that over the last year. And it just as a reminder, those timeframes were during the timeframes that were reviewed were part of the COVID pandemic time. So it was very high volume of work that was taking place. So even more of a compliment to the accounting team for that. And additionally, we have been growing. And so to make sure that we can support each and every staff member, we wanted to implement a new management structure, which resulted in hiring 2 new managers and 2 additional coordinators to again help the growing portfolio of work. And again, for the team to feel supported and that they have someone that they can reach out to and is available to help facilitate the work that's taking place. And in that same spirit, we also increased the frontline staff to actually do that work as well, being the environmental health specialist, 2 community health specialists, and 1 public health technician. In addition, with these growing partnerships and the growing body of work, we have over 200 contracts that need to get managed on a day-to-day basis. So we implemented a new contract management software called Crow Canyon. And finally, we updated our facilities to allow for updated computer labs that would facilitate community members to take advanced food safety training as well, which wasn't possible before those updates. So with that, we will move into looking at some of the highlights of the work that's taking place over specific communities. So we will start with the city of Selah. And in the city of Selah, in 2023 alone, we had our environmental health specialists that were very busy conducting over 180 inspections over the course of the 1 year. And again, that's just the city of Selah alone. And you can see the breakdown of what those different inspection services encompass. In addition, in the city of Selah, we participated in September in a community listening session related to PFAS. And just as a reminder, the issue in terms of contaminated water in the city of Selah is being technically led by the United States Army, but they are working in partnership with the State Department of Health, and the Yakima Health District is there to make sure that there's a local voice that can participate and help facilitate some of the work that's taking place. And as a result of that, the Yakima Health District team was going door to door in Selah, making sure that we could distribute some water filter pitchers and point of use water filters for those that kind of fell between a gap. Because technically, as I mentioned, it's the U.S. Army that's taking lead in this effort. And so they were able to provide services to those that had PFAS levels above the federal standard, but not the state standard, which is actually lower than the federal. So essentially, there were people that were caught in the middle that we received help from the State Department of Health to provide these resources for. So we'll move to the city of Titan. And in Titan, we were able to work with Central Washington Family Medicine to distribute over 295 masks that we were able to designate for agricultural workers. And this was done in preparation for wildfire smoke. And so thankfully, there wasn't as much this year as there have been in last year, but we were able to move those over to make sure those were available. In addition, through our SNAP Ed program, we were able to partner with the Highland Food Bank and the Highland School District to work together on a back to school event. That ended up being a really great event that provided resources to different families, again, in preparation for back to school, including working with Yakima Neighborhood Health Services to get an immunization event set up for children to be on track and vaccinated for their routine immunizations to get ready to go back to school as well. That was great because all the time slots were filled and all those services were made available. In addition, 5 pallets of fresh produce boxes were distributed and 200 food bags were made available at that one event. Then we'll move over to the city of Sunnyside. And in Sunnyside, our environmental health team has worked to establish a West Nile virus surveillance program. This program helps to actively monitor and track virus instances. So Sunnyside serves as a local surveillance site conducting mosquito testing and monitoring the virus presence. Something that is very important with the changing weather patterns. So it's great to have this in place in anticipation of future activity. In addition, the State Department of Health was awarded an EPA grant, which the Yakima Health District is collaborating with, and again, for water quality issues in the Lower Valley. And then finally, we just wanted to highlight one instance where the Sunnyside School District asked one of our staff members to provide naloxone training for a district-wide resource for nurses in October. And then we will conclude our tour with the city of Toppenish. And again, in the city of Toppenish, our environmental health team conducted close to 100 inspections over the last year. You can see what that ends up looking like. In addition, we were able to partner with the Yakima Nation to select a site for our naloxone vending machine, specifically at the Yakima. The machine itself was received very well by the community. There was actually a ribbon cutting for this event, which brought members of the tribal council chairman, as well as the Toppenish fire chief and different community members. And I'll go over some of the updates on the vending machines in the later report. And then the last highlight that we wanted to make was the awards that were provided to the city of Toppenish with the BRIC grant. And these were funds that were provided to the city of Toppenish to help with signage of a walking trail that's going through their murals. And again, with the intent of increasing physical activity. And I'm not sure if it's in place yet, but when it's in place, if it's not already, it will allow for incoming visitors to better walk through the area and admire the different murals and the history in that area as well. And looking into 2024, some of these goals we've already reviewed, but essentially talking about the growth, we want to make sure that we continue to have that office space that can facilitate that growth for the team, but then also the services that we're wanting to expand into as well. Having updated comprehensive solid waste permits and moving into more of the prevention initiatives related to substance use rather than some of the naloxone access issues that we've been working on in 2023. And then again, making sure that we increase our presence in the Lower Valley, starting with the expansion of the harm reduction program in Toppenish. And that concludes the presentation. Any questions?
Go ahead.
Really, and I just appreciate when we look ahead to 2024, looking at the Youth Prevention Education Initiative, and look forward to hearing more about that as it moves forward.
Absolutely. Thank you.
Just really quick on the SELA, the SELA slide, it talked about like 52 solid waste inspections. Is that like underground, what solid waste inspections? See, that's a lot.
Yeah, so we have our nuisance solid waste category, so we get calls, complaints of people have a lot of refuse in their yards, so we respond and issue notices that it needs to be cleaned up. We also have lumped in there would be the landfill facility on the training center. And technically the Caton landfills and Natchez, but that kind of got lumped in there.
Gotcha. Okay.
Yes. So.
Thank you.
Any other questions? I just want to congratulate you, Mr. Taylor, on 2 very clean audits and the work that you and your team have done on that. Thank you. You're welcome. All right, we will move on then to agency reports, and the first report is our Executive Director, Andre Fusco.
Thank you. Good morning. Good morning to the board and certainly our guests. I wanted to share my personal pride in the school youth. We have a wonderful team here, but it really is a collaborative effort. It's amazing how much this agency is able to accomplish in partnership with other agencies throughout the year. And I'm really proud of the team. It's exceedingly hard to be responsive to the community's needs. Certainly continue to meet the standards of spending people's money wisely, beating audit standards, keeping up the contracts. There's traditional public health work that we are obligated to do. It's really impressive. So I'm really grateful to the team and And I am grateful also that the team has embraced from the very beginning of COVID, the importance of financial responsibility. It's a real collaborative effort, and the directors certainly deserve praise as well, because we discussed the fact that we would be receiving a tremendous amount of incoming funds, and we had to be responsible for them, obligated, and we were going to be held accountable for them. And so it's been really a wonderful process, a growth process. So I'm really grateful. I wanted to share also that when we talked about the goals for 2024, part of this is assessing what we as a team can and should be spending our time on. We have really been in response mode since before COVID. I think it was the hepatitis A outbreak. So we literally have been for years managing emergency responses. I think that's been wonderful that we've been able to respond and we've been able to grow in terms of size and capacity as an agency, but it's also asking a lot of our team. So I'd like to spend this next year reassessing what we spend the time working on, our goals and our obligations, and certainly be able to invest the time to be prepared for some of these responses, because it really is taxing. And it, as I've shared with you in the past, being a responsive agency to the needs of the community is priority for us, but it also is something that we have to balance in terms of our other responsibilities daily. So I think the team is supportive of that. We are very fortunate to have new people who are very interested in public health service, but we want them to have a career here. And so we don't want them to go thinking about the next emergency. We want them to be thinking about their daily condition, their daily work, and how we can support them in the journey. There are two specific things that I'd like to be working on this year, and we've discussed it as well. One of them is to support our health officer in having backup. And we have discussed, and the board had shared input that they had interest in having a local relationship. And so we've been engaging with the Benton Franklin Health District on that. They are a health district as well as us. So they use the same risk carrier or insurance company, for lack of a better word, than we do, Endurus. So in terms of liability, I think that it's a nice mix. We've been in discussions, but it's moving slowly. But that is really a negotiation, something that we'd have to address with our board and their board in the future. But my plan in the next few months is to work with them on that. The goal again is we have to have a health officer who provides us with protocol. Dr. Bard deserves to have time off. We certainly want to be prepared in an emergency. And as we discussed, the plan was to have the local relationship with the regional health officer as a backup in the event of a true emergency. That's what the board said they were supportive of, and so that's what we'll be working for. So I don't know if you have any questions on that, but that's our plan. Okay. And then we again have done a wonderful job, I think, with Lillian's leadership, and certainly Ryan Chase's involvement in embracing the fact that the Spokane Regional Health District had stopped providing breast cervical health program services. So we stepped in at the request from the State Department of Health. I think our team has done an expert job in helping refine that program, build bridges, support increased partnerships. Am I covering everything, Lillian? And avoiding some of the diplomacy issues that come with taking over a program that we weren't prepared to take over. Having said that, I think it's unfair to have to continue to provide local resources for a massive regional effort that really goes all the way to the border. So I'll be working with the State Department of Health to talk about a supportive transition either back to the Spokane Regional Health District or an agency that wishes to take it over. It's a really critical program and we're grateful to do it. But I think to do it to the level that we require and we expect would mean hiring more staff, and then it would become a permanent responsibility, which is not what we obligated ourselves for. So that again is part of our reassessment this year of where we spend our time, how we spend our time. I'm grateful as an example that our reputation and our process and our professionalism extends all the way to the west side, and that people respect our ability to get things done. Well, we have become accustomed to people asking us to help them with their responsibilities. And our job is to create change, support change, and then step back so that we can focus on our mission. So that's something that I'll be working on. And again, we're looking for a supportive, healthy transition rather than dumping a program onto an unsuspecting agency. The people in those communities deserve to be supported, and I will share with you that I've heard from many, many jurisdictions who have appreciated not only our work, but a recognition of the services that prior that they didn't realize were available. So it's been really an impressive lift by our staff. And then the last piece is that we'll have updates on our work with the distribution of Narcan. That's something that we have been working with and supported by the board on this year. Really impressed with the partnerships we've built on that and rapid distribution. So that's all for me. I know that we had an executive session, so unless you have questions, I'm done.
Questions? If not, then we'll move to Chief Operations Officer Ryan Miller.
Okay, the first thing I'll talk about is emergency preparedness, give a couple of updates on that. One thing that we've been working on is with Camp Hope on measures to help the homeless population and for cold shelters for extremely cold weather. I know Andre spent a weekend working with their buyers and other community members on making sure that the homeless population was protected. Also in Mapton, we continue to provide technical support for safe drinking water on their drinking water issues. Internally, we've talked about the last couple of months of doing a remodel for the health district for 3 reasons: staff security, for client privacy, and then also to provide more office space. So we're moving forward on that. First step was to select an architect, which we've done. We've selected KDA architect, and so we will be starting to meet with them on pre-design. It's about an 8-week process to do the pre-design. We'll be meeting with the architect, our executive committee, our advisory committee on how we're going to do that. The nice thing about that is we're going to be doing a pre-design, and we own that pre-design. And then after that's done, then we can decide how we want to move forward. If we want to move forward right away, then we can do that. If we want to wait, or if we want to even, hire a different architect or move in a different direction, we can do that. So that's kind of nice that we can actually break it into different steps. And then the next step would be then we do a sealed bid and hire a sub or a contractor. And then after we go through that process, the next step would be the remodel. So it is a long process, but right now we're in that next step where we're going to be doing the pre-design. 2 months. I'm sure with the board. Yeah, and so part of that pre-design is a cost estimate, and so we'll be getting an actual cost of what it's going to be, and then we can make that decision at that time too, when we get that pre-design. And then finally, positions at the health district, we have done interviews for development and disabilities transition specialist, which we have offered that position. So we're very excited. That person will be starting on February 12th. And so you'll be able to meet that person next board meeting. And then last week we did interviews for public health partnerships coordinator. And so we're in the process of making a decision on who that will be in second interviews. And so possibly next month we'll be meeting that person. So that's all I have.
Any questions or sidelines from me? All right, then we will move ahead to some.
All right, good morning, everybody. The financial reporting starts on page 11. I actually have 2 months to report on. I will move through November fairly quickly. And if you have any questions, please stop me. Otherwise, I'll move through it quickly and spend a little bit more time in December. For the month of November, we had a $269,000 gain, bringing our excess revenue for November to $2.2 million. Our allocated budget through November was $9 million, and actuals are coming in at $10.9 million for revenue. And for expenditures, our allocated budget through November was $9.3 million, and our actuals are coming in for expenditures are coming in for $8.7 million. Any questions on the summary? Moving into the income statement, I'm really not going to speak too much right now. Moving to page 12 into page 13. I will say with the gain for the month of around $200,000, that was mainly Mac billing administrative admin slain. That is an additional billing that we entered into arrears with during the COVID that we're catching up with now. And that's been a pretty penny so far this year. So Mac billing has been very, very beneficial to us. A lot of that has to do with our COVID operations at the time. Mac billing has a lot to do with our nursing and our medical staff, the operations that they were doing. And at that point in time, we were doing a lot of COVID stuff. So that was generating a lot of Mac activity, as they would say. Moving into the programs, Much of the year was foundational public health. That's all the keys. A lot of that is timing. We had a transfer. The foundational public health has a fiscal, July through June period, and while we have a calendar, so that creates a carryover for the next year. And that's what's happening there. That is actually funding that we brought forward from last year. Any questions in the program section? Okay, COVID. COVID activities have gotten increased quite a bit. Not much to note here, unless there's anything. Again, I am moving fairly quickly in interest of time. If you have any questions, please stop. All right, December, year end. For the month of December, we had a 56,000 gain in excess revenue, bringing our total excess revenue to 2.2 million for the month of December. For revenue, we budgeted 9.9 million, and our actuals coming in $11.8 million, which is a almost $2 million excess as we expected. Then I'll explain a little bit as we get into that. For expenditures, we adopted a budget of 10.1 million, and our actual expenditures were closer to 9.6 million. For expenditures, when the board approves the budget, it is much like a Price is Right model, up to but not going over. So we actually got really close. We set up 95% of our budget without going over. So it's actually pretty close there. Any questions? All right, moving into the income statement. Our foundational public health services generated $2.7 million this past year. This is really our future, is FPHS funding. That is what we're going to be our main funding source in the foreseeable future. So that is great to have that. Our federal and our state, at least compared to budget, kind of flop. We expect it to be a little more federal in the state, but they're comparable against each other. The surprises this year, developmental disabilities, there was a large increase for our providers. Much of that is pass through. So a lot of that went to the providers that provide developmental disability services this year, which was excellent to see. Those companies kind of struggle from times, and so it's really good to have that additional funding for them for their service. The largest increase, the largest surprise this year was investment income. $840,000. That's quite a bit more and that's really has to do with how the economy rebounding. So last year that was just around $100,000, and so that is definitely a major shift this year, and that's all mainly market driven. Moving into the expense section, I'm just going to touch on some of the large overages, the large compared to budget, and then if you have any questions, please let me know. Our payroll expense is definitely one of the larger differences. We were a bit undermanned this year. We're still continuing to re-up our staff, and get closer to that. The part about the benefits can be a little tricky is there's quite a big difference between a medical insurance for a single individual versus a full family, and so benefits. We always want to have a little extra in there in case we have a lot of people going towards a full family. We want that to be of option to our employees. Enhanced program was another major difference. We did not spend a lot in the enhancement program. Moving down into the other expenses. The largest differences are kind of towards the bottom here. Our provider services, medical, federal, and state, those are BCHP services. And again, that's similar to our revenue. That's kind of flop between each other. And the provider services, you can see the DD right below. We expended about $2.7 million for those services, which is excellent. That is out in the community providing a very good service. Contracted services. The difference with that is for our Acela, for environment, which is our catering consultant. Next page, big difference in the building, the small repair and maintenance. That's a lot to do with our building. We've got a paint job. This office here has been updated, moved into the 21st century. Is there any questions? I went very quickly.
Just on the revenues, for the flip we've seen with like our federal and our state dollars, is that something that stays kind of status quo from year to year, or are they always?
They kind of do always. A lot of it actually has to do with the DCHP program. Sometimes the federal will pull in, and if the federal pulls out, the state will fund more.
Okay.
And if the Fed funds it, the state will pull more money out. So it's a give and take with that one.
Right on.
We actually had a situation, I guess it's been about 8 years ago, where the majority of the funding was coming from the federal government. And then they reduced it. It's really a complicated program because you're not just providing for the care to assess a patient, but then you're paying for the follow-up care. Then the state realized that the program was either going to fold or they were going to have to start investing more. So it really was a philosophical change for the state, and the state has been able to keep up, if you will, to fill the gap in the federal.
And on the investment income, the way it works is, do we leave it there to continue to grow, or does the organization take out that investment?
It continues to grow.
Yeah.
Yeah, that's admin by Yakima County.
Yep.
The treasurer's office.
Chase, just on the note about that, getting the $2 million revenue over projection. Obviously, 700,000 of that is the investment income. What do you attribute most of the rest to?
So the majority of the other piece is MAC billing. We actually generated $670,000 in MAC billing this past year.
Okay, what did you mention?
A lot of money. And then most of that is, we're seeing a shift from foundational public health services from flexible dollars. So it's $1 million that we receive every year. Flexible dollars can be spent any way here that we have. And so that contributes for the remaining overage.
And then the Medicaid administrative claim amount, that's really a one-time.
Yes, yeah, it's not gonna happen year over year. It has a lot to do with the COVID dollars. We had a lot of money coming through the small agency during that, while we're funding state help the park, doing the vaccines and the testing. Millions of dollars was passing through this, and that's decreased quite a bit. And the MAC billing has a lot to do with how much expenditures you've had during that year. COVID expenditures kind of dropped off a cliff, and so MAC billing has been high up. It's been $260,000 of billing. I'm expecting that to come down to closer to like $100,000, $90,000 of billing. So for this next year, we're not going to have that kind of excess in that program this next year.
And because the Medicaid administrative claim program is to serve that specific population, there's certain programs that we do that serve those people. During COVID, we were really serving a much greater a number of people, a much larger population countywide. So it changed our reimbursement environment.
Yeah. They have what they call different cost pools, nurses being the highest part of the cost pool one. There was actually a meeting a few weeks ago. They're planning on maybe expanding that immunizations, emergencies. So hopefully there might be some more generation. It won't be what we've had this past year, but they're talking about maybe expanding that funding. So it could get increased year over year.
Thank you.
Any other questions?
We like the price is right model on it.
It's always good for one I like.
Yes.
Moving into the programs, not necessarily speak to any individual programs at this moment. I would point to 295. It's not really highlighted on here, but it's in the, gosh, I think we call that the clay section, number 295, Medicaid admin match. We had a $670,000 gain in that particular program. That's really the majority of our excess this past year. Moving into the next one, the slight unders that we've had have to do with additional FTEs. We're needing those people towards the food program and solid waste. Any questions?
Where does the Medicaid admin match come from?
It's the HCA, the Healthcare Authority. Yeah.
And what is it matching?
So it's, gosh, it's not necessarily matching dollar for dollar. What they have is they call a MER rate. And I'm not exactly sure how they calculate that. We input how much revenue we have, how much we've expended. And at that point in time, we were had a lot of FEMA funding coming through. So we were expending, $5 million and FEMA was matching that. And so as we're coming in with the MAC billing, because of all of that dollars that are passing through, that created additional MAC revenue. About $200,000 billing. And this is quarterly billing for that MAC revenue.
And if I'm not mistaken, it's federal dollars that come to the state as a whole, and then it's distributed out to each jurisdiction.
Right. Hey, all right, COVID. For that, we expended about $340,000 this past year, the majority of that being in payroll expenditures and advertising, messaging to the community. Good question. I guess I do have a question for the board. Is this report, as COVID is kind of starting to quote unquote go away, the funding for that, the activities for that is starting to decrease. Is this a helpful report? Do we still want to continue to do the COVID report into 2024?
Well, I guess for me, just, still getting familiar with this board, but like, are any of these monies that you're highlighting monies that we're going to be returning if not utilized?
No,
Okay.
no, not for COVID funding. COVID is reimbursable, so as we expend it, we'll send an invoice to DOH, they repay us, yes. So we will not be sending money back that is related to this program.
There have been some discussions at the state level that we've been allocated certain amounts of money. We certainly aren't using all.
Right.
So there may be a request for reallocation, but it's not going to meet the cost of the health district. because
Correct.
We're not using the funds.
Yes, that is true.
Any thoughts from the board and in response to Mr. Porter's question?
I guess for me, I'm indifferent. I do know it takes some amount of time to put together every single month, but if other folks feel it adds value but I feel like we're over COVID in my opinion, so.
That's the gamut here.
Do you anticipate the same, what level of funding do you anticipate for COVID dollars in 2024?
Not as much in the previous years. I'm actually expending probably $300,000 to $500,000, but we won't expend that. It'll probably be closer to the same as what we have now. As that activities kind of lightens up, it's not as a big of a threat to the community. We're shifting our focuses to the foundational programs.
And actually, is it May of 24 that a lot of this?
May, June, yes, May, June, a lot of this is starting to sunset. There's been emails going out from Department of Health asking, and a lot of other counties are way under, quote unquote, underspent in the COVID activity. So they're seeing that across the board.
And it actually started with an extension of these funding streams for years. So when we're talking about these, this wasn't that we anticipated spending this much money, it's that we allocated this, I guess, in 21 and 22.
Yep, and 21, correct, it was at that point in time, we weren't seeing an end in sight, so to speak. And so they allocated substantial funding to help fight that. And as we moved along and we're not seeing that we're needing.
My thought is that it's just right now, it's extra time for you. And unless something significantly changes, I don't think we need an individual report on this, but it's up to the board.
I might ask a question, as an alternative to this breakout report, are you recommending we just make it a category like the rest of the
Yeah,
categories?
it already is, but it's grouping 325 through 328 onto one report.
Yeah, I'm good with removing it.
Do we need a motion on this, or we just have consensus agreement? It seems to me unless you object, that's the consensus of the board that we really do not need to have that individualized, so thank you.
Well, thank you. And if we can actually change that, if your mind changes about that, if something happens, we can actually bring that back if that's what you want to do. So thank you for that.
You're welcome.
Moving into our cash flow report for the year end, so we have $13 million in our total cash and cash equivalents. I do expect to see an uptick in January as we'll see foundational public health services as well as collecting dollars in the month of January.
It's really interesting to look at the amount of reserves we have as a health district, because at the cities and counties, we struggle to keep a bare minimum of 3 months operating cash flow. But for us here, we have well over a full year of operating cash flow. And I don't know if that's always been the case for this organization, but that's an extremely healthy place to be.
Well, when I came in 2012, we were still under I would say an austerity program here. The board was very adamant because there had been some history where the health district had overextended itself and I believe had been granted funds or a loan, if you will, from the county. It was clear that the board did not want to get there, so we were quite conservative with spending money at the expense, though, of the fact that we, in concurrence with the fact that the state wasn't spending a lot of money in public health. So it really wasn't a wonderful place to be, but it did grow our cash balance. Having
Feel obligated to send some of that back to the community.
I think it's definitely, it was a loan. I do recall.
Leave alone.
But one of the things, it's an interesting point though, and one of the reasons that, and I'm glad we're discussing it, if you mind just briefly, we can talk in the future. It wasn't this robust before COVID. And so it came at a great cost and that's why it's larger. One of the things that we're attempting to do as we employ this catalyst model is how can we share our resources with other partner agencies in the community so it benefits not only the public health mission, but also benefits our partners and strengthens the services that we provide to individuals who may not know where that money's coming from or may not know the partnership or the programs, but their lives are improved because we're doing it. So we feel an obligation to do that. And that's something that I'd like to talk to you in the future. Again, that's one of the reasons why I'm hoping you can spend less time in the future. I hope to say it because now it'll come true. Responding to emergencies so that we can talk about the healthy balance that can be used to benefit the community.
That wraps up my report. Thank you.
Anything else? Mr. Brewer, you want to? If not, then we will go to.
Have a selection of not necessarily related topics to speak about. First is syphilis. So we now have the highest rate since 1950. The numbers of medical students are the ever saw a case of syphilis in the hospital. And the number of cases in Yakima is following the national trend. So in 2022, which is the latest year that data is available, there were 207,000 cases of syphilis in the United States, which is amazing. Along with that, there has been 3,755 cases of congenital syphilis, which often leads to stillbirths and infant deaths after successful birth. So very huge problem. The health department at DOH have a collaboration on case finding and treating. And I remember some months ago, our major case finder had 90 active cases in the city. And that's too much work for one person to do. And the state has expanded the budget for the case finding. But the real defense against this is good health, public health infrastructure. So making our agency as healthy as possible is going to be able to defend against continued high rates of syphilis. The syphilis is not confined to traditional populations, but the majority of cases are. So groups like people that are living without homes, that's a big issue because of just the way things work when you're out on the street. And the health district is partnered, as Lillian said, with organizations that are dealing with unhoused people. There also is a penicillin shortage at the same time because of the number of cases and the fact that the way drugs are manufactured these days, it often goes overseas to a single factory. And if that factory is found to be inadequate on inspections, the FDA goes overseas and inspects those places, the factory's closed, and then we're without the drug because it used to be multiple companies making it. And now because of costs, it's not. There is a little shine in the future. There's another product that's available that I don't know if we can get our hands on it yet, but it's just different preparation of the same drug. And they expect by this summer that the supplies of penicillin G will be back up to adequate levels with new plants coming forward. So that's some bad news. Again, your continued support of the health district is a major defense against further propagation of this really epidemic of syphilis. Good news, the incidence of hepatitis C has decreased among patients with HIV, which is likely related to the better drugs that are now available to treat hepatitis C. So drugs are so good that about 90% to 95% of patients respond and they don't have any measurable viral load, therefore they can't transmit it. So those new drugs have been out since 2008. They're easy to give. They were expensive. Now they're covered by insurance and they make a big difference. Another good news, a study was done on the quadrivalent flu vaccine. That means there's materials in that vaccine that will cover for 4 prevalent strains. It's led to 60% greater protection in seniors with decreased rates of hospitalization and decreased rates of serious illness. So again, it's a great vaccine. It's working really well. There's a study done in England. COVID's not over, unfortunately, Kyle. He's still with us, but there's some interesting research going on long COVID. I know there's been questions asked about that from the board in the past, and it's a real thing, and it's a clinical symptom complex that can be diagnosed. There's some interesting stuff in the wings regarding blood tests that are measuring markers of inflammation, and it appears that a combination of 4 of those markers correlates to about 79% accuracy with diagnosing. So one of the things that potentially could lead to is if there's agents that modify the levels of these markers, it may be helpful in treating long COVID. And what happens in long COVID is just continued stimulation of the immune system. Normally, you would have a reaction, the reaction would taper, and you get over it. In COVID as well, some other diseases that cause symptom complex grouped under chronic fatigue syndrome, there's continued overactivation of the immune system. So possible interventions in the future based on the ability to diagnose the disease on blood tests. The JN1 variant is currently the most prominent COVID variant in the United States. And the latest vaccine that was available in August and September does provide coverage against that new strain. However, the uptake of that vaccine has been really low. The new strain also responds to Paxlovid, and the number of people getting prescriptions for Paxlovid is also really low. Having taken Paxlovid, I tell you, it works really well. Basically, you feel better the next day. So encourage people to go and get that if they get COVID. I think pharmacists in the state of Washington prescribe it. You don't even have to go see your doctor. So not hard to get.
We have a question, Dr. Burke. Thank you very much. Commissioner McKinney, you have a question?
Oh, thank you. Just a comment. I would say that to Commissioner Curtis's point, I think what I would offer is that COVID, of course, as Dr. Vargas says, we know will be with us for a long time, the virus itself. It's the horrifically damaging policies and the reaction that stemmed from COVID that, thank goodness, we can say are behind us and hopefully never to be repeated.
Thank you, Commissioner. Dr. Burke, go ahead, please.
So last COVID-related thing is that COVID, RSV, and influenza are all still going on, and many hospitals in the state, including multi-care system, have reinstated mask use for healthcare providers at the hospitals to decrease transmission of these viruses to susceptible populations, which is basically most people in the hospital. So Memorial, being part of the multi-care system, is encouraging employees to use masks when they're patient facing. Okay, moving on to HPV, human papillomavirus, which is the cause of cervical cancer. The study was done on girls that were vaccinated between ages 12 and 13. They followed them for a long time, and there were no cases of cervical cancer in that population. So very effective vaccine. We're actually going to start looking at its use in Yakima County to see if it can be improved because of its effectiveness. It's been in use since 2008, and the incidence of related HPV-related cancers is going down. It'd be a shame to have it available and not get it and develop cervical cancer. So measles outbreaks. There was a number of outbreaks in Europe among non-immunized kids. In the United States, measles was basically eliminated. But there are unvaccinated kids, so if they get exposed to somebody who has measles that come in from overseas, then they can get measles, leading to local outbreaks. Last month, I told you about a Philadelphia outbreak of measles. Right now, there's an outbreak in Clark, and I can't say the name of the next county. Why yeah. It's not a big outbreak, but there are cases being reported right now. There was a large outbreak in Ohio, again, exclusively non-vaccinated children. So when the pediatrician offers vaccination, even though you might have not seen a case of measles in your entire life, it's out there because people are coming into the country from overseas from unvaccinated populations there and bringing it in. If they didn't come over with measles, then the kids who are unvaccinated wouldn't get it. If the kids were vaccinated, they wouldn't get measles. For those of us that were alive before measles, there's a high mortality rate with getting measles as a child. And it's particularly bad in developing countries where nutrition is lower. The death rates are even higher. So we can't lose our vigilance on childhood vaccination. Last item we'll talk about.
Dr. Barr, the Ohio cases, were those in Amish populations or was that in general?
It didn't say where I read that, but if any group has low rates of vaccination against that particular agent, they're going to get measles once exposed to it. So, the last thing I want to talk about is Narcan. There was a study done in New York where a low dose, 4 milligrams versus a high dose, 8 milligrams, worked just as well. The effectiveness was good. Now, sometimes doses don't work because the patient is going too far. They've had respiratory depression for too long. They have cardiac arrest that, by the time the first providers get there, it's just too late. They might have had massive aspiration, which happens a lot in overdose. So for people that you get to soon enough, the low dose is good. And of course, that's cost savings. It costs less. So Narcan's still the best defense against overdose. And that's it. Any questions? Happy to answer.
Questions for Dr. Barton? All right, if not, we will move on. Thank you, Doctor. We will go to Melissa sixth grade for Jesse Skinner.
I'll start with our respiratory illnesses. Our flu activity within Yakima County is starting to trend down, so that's great. But we have had 4 influenza-related deaths in the county so far for this 2023-2024 year. We on Monday did our first child fatality review and prevention meeting that was well attended and well received. It was a great meeting where we reviewed the suicide deaths of 5 individuals from the 2022 and 2023 year. And together collectively, we came up with actual tangible things that we could look at for outcomes that may prevent something like this from happening in the future for those individuals. So we're looking forward to working with partners throughout the county and continuing to develop that program.
I think Melissa's being a little humble. The amount of work that she and members of our team that you've seen and working on, it's really been tremendous. And the other thing that, if I may, if you could share the distinction between child death review and child death prevention, please.
Yeah, so a lot of times these child death review committees come together and they review these children's deaths, but they don't come with a plan for prevention. It's just to review the deaths. And our real objective is to see what we can do in the community. Where's the holes in the system where we can come together and make change and prevent things like this from happening in the future. We can't prevent every suicide death or every child death, but we did identify some things that if had been in place could have prevented these. And so that's what we're looking to do for prevention.
Melissa, I know you probably said this at the last meeting, but childhood, are we talking under 25 years of age?
18.
18.
18 and under. And there's a real push. nationwide, there's been an increase in child deaths, with what the state says is, unacceptable, is the words that they used, unacceptable rates. And so there's a real push nationwide to get these programs up and running that were running pre-COVID that then, were discontinued. And so there's a real push to get these up and running again.
Melissa, who are the partners that are involved in this?
So we have the coroner's office, was here, a couple detectives from the Yakima Police Department. We have CPS here, DCFY. We had, ESD 105, so our school systems, and Safe Yakima Valley was in attendance. And then as we're working through this, we're identifying more partners that we can have at the table, such as mental health providers. We also had a local pediatrician that was here.
So this is exceedingly hard work. It's very, very painful to review the deaths of children and the circumstances of their loss. It's exceedingly painful work. But it's necessary work because it's so important to avoid those catastrophes. So I'm really grateful again for the leadership of Melissa and others, because we're trying to engage in a real true relationship with our partners who again feel this incredible responsibility to address this and prevent these from happening in the future. And it's a real honor for us to be engaged in it.
Commissioner McKinney, your hand is raised.
Thank you, Ms. Chairman. I just wanted to ask if membership could be inclusive of a parent who has gone through this tragic situation, just as another additive to the conversation with all of these groups of experts.
It's, it absolutely can be, and some child death review committees do have a parent on there. But sometimes for the parent, it's too much to review that and then to review other deaths as well. So having been our first meeting, we have not gone down that road yet, but something that potentially, given the circumstances, if it's a natural death versus, we had a very touchy subject on this one, on suicide. So it could be very traumatizing for.
It is
come in.
incredibly sensitive. It's horrific. There's just nothing worse than losing a child. And so acknowledging that, and that's why I think there would be an additive only if, as you say, if someone felt they had the ability to do so. So I appreciate that. And I also recognize that I'm certain that most of the folks who are on that group are parents themselves. So it's easy to put yourself in those shoes, unfortunately.
Commissioner McKinney, though, you bring up a wonderful point. We saw during, we had years ago a rise in anencephaly cases where children were being born but not viable births. It was tremendously painful and traumatic for those families. The loss of a loved one in these circumstances also impacts those families. So that's something that we certainly can consider in terms of support for those families and how we can provide resources to them.
So our next meeting will be in April, but between now and then, we'll be working on things that we determine were actual things we could come up with for prevention. So we'll continue to work on those, and I'll have updates over the coming months on what those are. We are also working on expanding our harm reduction program to the Lower Valley. We've identified a location. We are finalizing the contract with the business owner down there to have a location. That our anticipated first day down there will be March 5th. All of our services that we're offering up here will be offered in the Lower Valley as well, including naloxone, STI testing, behavioral health referrals, addiction referrals. And I also wanted to give some numbers on our harm reduction program here in Yakima. We've changed the way that we've been collecting our data as requested by the board. So we had for the month of January, we had 138 encounters where we encountered individuals. We had 115 unique clients, meaning 115 people in attendance. Some of those were multiple. So we had 97 individuals that attended once, 14 that attended twice, 3 that attended 3 times, and 4 people, or one person that attended 4 times. And then we had 7 people who in the month of January who were noted to be secondary exchange, meaning that they were coming in for not just themselves, but for other individuals as well and exchanging for them. Predominantly, we served a male, white, 30+ age range with most of our clientele. We exchanged almost 5,900 needles. We gave out 105 fentanyl testing strips, 23 sharps containers, 550 condoms, 5 social service referrals. And then getting into our naloxone, we gave out 215 doses of naloxone and reported back 52 of those were used. 47 of those individuals lived, 2 of them died, and 3 were unknown. Most of those occurred in public areas. 28 of those overdoses were in public areas, whether it was a motel, a shelter, on the road, and 22 of them were in private residences. Comprehensive attended 2 out of the 4 weeks, which we now are working with another one of their programs through the Hub and Spoke. So we will have coverage every week that we're out at harm reduction through Comprehensive. Within those 2 attendances, they had 30 encounters with individuals and 2 people scheduled for addiction treatment services. My update, unless there's any questions.
Might have a question, Melissa, as I'm looking at these, these numbers, and I really appreciate the work that you put into, breaking out this data. It's really helpful to me. And I guess I just, when I'm looking at our year before data, when we look at the unique encounters and then the people that were actually admitted to or referred to treatment, well, let's go to admitted to treatment. So, it's less than 1% of the people that pass through there that were actually getting to treatment. Are there thoughts about how we can improve that number?
Having somebody out there every week will be helpful. But this is also, excuse me, a group of individuals that have our age bracket is 30+. These people have been using for years. And so it's a really tough crowd to convince to get into recovery. These aren't typically have addiction for 6 months. I mean, these are years and years of addiction, and it just takes that repetitive interaction every week, interacting with them and just meeting them where they're at. And hopefully one of these encounters, they will accept the help.
If you can remind me, I know that one of the things that was hoping you would talk through is having people with lived experience be there on site to have those interactions. Are we successfully having that happen on a regular basis?
So currently we have every other week is what Comprehensive was able to do. We've talked with them and working with an additional program that they have. So we will have coverage every week down in Yakima now, which will be helpful. And then for Toppenish, the tribe, their behavioral health services will be out there every week.
Thank you.
At the end of your part, Melissa?
Yes.
Okay, are there any other questions from us at this point?
Out of the 2 Narcan vending machines, which one's getting the higher usage? Is it the Toppenish?
Toppenish, and Lillian has that in her report.
Oh, she-
Number.
okay.
Yeah.
I can briefly just mention, it's not very long. So from the 2 vending machines from the last meeting, there was an 80 additional Narcan kits that were dispensed between both locations. But it is the Toppenish location that is seeing the most traffic, especially when you look at the population rate. And just really quickly, and then I'll conclude so we can go back to Sean. There was 250 total since the implementation of November 1st, 124 in Yakima, 132 in Yakima.
Thank you.
I just wanted to see if the coroner had anything to add. I know I spoke with him Friday evening. There was a potential overdose cluster that was identified through the state for Yakima. So I reached out to Jim to see if I was missing anything, but if you had anything to add on overdoses and what we're seeing.
Just that we do get clusters that'll come in. If you watch EMS you'll see that they'll start administering, going on unresponsive people, and they're administering Narcan, turning things around. When we get a cluster, we'll get usually about 3 or 4 deaths out of that, which was about last week about this time we had what's this? Right before Christmas, so we had another one, which resulted, I think, about 7 deaths in about 5 days.
When we say cluster, we're not talking like in the same location, but
No, just a time frame. Yeah, yeah, and the location it's all over the map. There's no rhyme or reason to they could be out in Mount or Napton versus down here.
Is it presumed to be hot doses or is it presumed to be?
That's my guess is that when we get their toxicology back, the people will have 50, 60 times the lethal dose of fentanyl versus. And there's also a lot of we're finding cocaine. So fentanyl, which isn't new, but it seems like some of the decedents family will say, yeah, they've never used opioids. The drug that was actually found consistent with cocaine.
We're gonna move then ahead to to Sean McGee, but thank you.
All right, good morning, everyone. We introduced Noe earlier. He's one of a few newer staff that we have in environmental health. So winter time is a time for us to do a lot of training and cross training and cross programs to kind of strengthen our response times and our abilities to work in land development during the busy season. So we're actively working on that. Quick update, the Washington State Environmental Health Association, or the WSEHA, has an annual education conference every year. This year in the spring, it's here in Yakima, so we're really excited about that, and great timing because we have newer staff that can attend that and kind of learn and gain knowledge about the broader scope of work in environmental health across the state of Washington and somewhat in the, on the national scene. So we're excited to have some folks attend that this spring. Moving into solid waste, we're actively working with other regulators, coordinating with the Yakima Regional Clean Air and Department of Ecology, reviewing documents and information that DTG has submitted in terms of getting new sets of permits in place to resume operations. So we're actively working on that and going through kind of combing through the finer details of that, of how they're gonna resume operations and trying to get that timeline set. So at this point, there's no real hard date in mind, but we're making progress. DTG is making progress and just trying to move forward there. So a lot of work being done around that. Moving to Lower Valley with the Guama. We're partnering with Yakima County Public Services. It was mentioned the Spotlight will do kind of our soft launch of going out to residences in the Lower Valley doing well user surveys. It will be a survey we'll conduct with the homeowner and resident about their knowledge of drinking water and their well, demographics of the household, just collecting data that can be used in further efforts down the road. Getting safe drinking water throughout the Lower Valley of Guama. We'll also be with the goal taking a certified laboratory sample of that well and getting those results back to those folks. And that'll include a nitrate sample and coliform. So we'll follow up with those folks and provide information and what resources are available for them, including potential for bottled drinking water delivery on an interim basis till we can get reverse osmosis filters, installed in their home, which would be point of use, not point of entry, meaning it'll serve one faucet in the home, but the goal is they'll at least have safe water to drink and cook with. So, which is the primary route for exposure to nitrates in drinking. We're also working heavily in the East Sela area in response to the PFAS contamination in groundwater. We're looking at, we have funding through the State Department of Health to look at expanding our some of our testing areas beyond what the Department of the Army has done. A big goal of this is to really try to explore how far this plume of PFAS has traveled in preparations of potentially doing a feasibility study in that area on would a series of community water systems be a solution, or would like a small municipal system potentially be a solution for safe drinking water to the folks that reside there. And what we don't want to do is undershoot, how expansive that system may have to be. We want to get as much information as possible and be confident in that if there was a possibility to move forward with the municipal system, we would capture everybody who would need that service. So a lot of work going in there. Additionally,
in late December, we unfortunately had, a home inspector enter a well house and, there was oxygen being displaced in that well house by gas, either H2S or methane is the belief, but that person, ended up passing away from that event. This has triggered, discussions with the state, environmental health team on what well house safety and confined space safety looks like for local health jurisdiction staff is doing a lot of these inspections. The state does a lot of these inspections for water systems. So it's, this very well could change the landscape of how water system inspections are conducted to ensure that there's safety for staff, there's safety for system operators, and safety for residences who own these water systems. So it's a big deal that we're looking into and exploring and making sure that all those involved in working around drinking water wells are safe. I know we have more to talk about later in the agenda. So I'll wrap up my report.
Well, one thing I'd like to add, I don't know, we've brought to the attention of the board, but Sean's been elected at a statewide position.
Oh, yes. I thought I may have said that in the past meeting, but every October we have the statewide environmental health directors conference. Where we all convene and talk about major issues that we're all working on, what our goals for the next year are. And I was elected the incoming chair of the statewide executive committee. So I monthly sit down with the State Department of Health, Environmental Health Administration or management team. There's the outgoing chair, the current chair, and I'm now the incoming chair. And we discuss issues around regulations and rule making, different, upcoming issues that are gaining traction and need attention and how we can address them statewide. I will be for the next 3 years committed to that executive committee, working on how we best address, public health threats in the environmental health spectrum. So,
Congratulations.
yeah, we're excited about it.
Actually, a fun fact, they've been hounding us to share Sean for many years, but during COVID, we thought it was important that he stayed. But we're excited about his leadership. Do you want to explain how it switches from east side to west side in terms of leadership?
Yeah, so every year at that conference, a new incoming chair is elected, and to make sure that the entire state is represented well in that committee, it switches back and forth. A west side representative is elected 1 year, the following year, east side director will be selected as incoming chair. So there's always representatives from both sides of the state, which is critical because the regulations and the way things are regulated by local health is different in a lot of ways when you're talking about Puget Sound, surrounding counties, and more rural east side agricultural type counties.
So the capital's on the other side of the mountains, and so we want to make sure that people understand the unique needs of Yakima County and also Eastern Washington.
Mhm.
So it's yet another way for us.
Wonderful. Any other questions or comments from Mr. McGee? Then, Lillian Bravo for Public Health, do you have any further reports?
Yes, to continue with the Narcan access update, as I mentioned the numbers from the vending machine earlier, but I did mention last month that we were looking at how we could partner with first responders to distribute some of the Narcan that we had available as well. We were able to do that last month, but we passed over 300 naloxone kits to Yakima Emergency Management, which then was able to facilitate transferring those doses to first responders. And they're all accounted for as of Monday. So we are looking at how we can move over some more naloxone directly to EMS to then give out directly to first responders. Most of those actually were provided to fire departments, with 100 going to Yakima Fire Department and a couple others across the county. The piece that surprised me, honestly, was that 72 actually went to the Washington State Patrol as well. So again, just you're hearing lots of numbers. It's a lot of naloxone that's being provided in our community, and luckily we're able to get it into the hands of first responders who really need it the most. And so just for some background, we had additional naloxone supply available because we did think that there would be more businesses essentially that would sign up for that pilot program. But with that having been sunsetted, there are a couple of other organizations and businesses that are interested in getting naloxone for their staff and have on hand. But it's less than we had anticipated, and that's why we're moving to move the naloxone over to first responders. And as well as with that, we know that this is a one-time availability. It's not something that the Washington State Department of Health can provide to first responders moving forward, unfortunately. But Melissa was able to provide information to these first responders about how they can get the best price available moving forward for their supply. And then, any questions on that?
So do we plan to purchase an additional large quantity of Narcan or as a health district, or we're kind of done with?
Not at this time, but I think once these efforts are done, we can reevaluate to see the need as well. But honestly, the focus has been on getting people signed up as distributors through the Washington State Department of Health specifically. And again, through the Washington State Department of Health in organizations such as homeless shelters or others who are serving people that are at high risk of experiencing an overdose can actually get these for free from the State Department of Health.
Gotcha.
And so that's the sustainability aspect that we're moving towards. Unfortunately, it's not available for first responders other than the Leave Behind program, which is very specific.
Then we also have a partnership with Yakima County too.
Yes, and that's ongoing. And so I'm happy to share once that, but I know Yakima County did reach out because they're hoping to get naloxone from the Yakima Health District as an organization and specifically to be able to fill their first aid kits. And so once we have concrete numbers, I'm happy to share that update as well. So that's great in terms of making sure that we can move forward with ensuring that everyone has naloxone available within the spirit of it could happen to anyone. And I think that that's important to include as part of your first aid kit, which Yakima County is interested in moving forward with. And then, excuse me, related to prevention specifically, I just wanted to remind everyone that the approach that we're taking, again, because it is youth, is working directly with organizations that are already working with youth in schools. And for that reason, we've been focusing our efforts on working with ESD 105, which is essentially holds the contracts for the different community wellness prevention initiatives across the county. And so with that, we're supporting their existing efforts to hopefully expand those. Some of those have started. The curriculum Strengthening Families actually started last week here in Yakima. So we're supporting with that on the outskirts, but then also on February 6th, there's going to be a Healthy Youth, Healthy Families event taking place in West Valley. If people are interested, I'm happy to share information on that. Again, a reminder that those events are to bring families together, but also to bring awareness about what the signs are to look out for if your child is having substance use issues. And the piece that we'll be most closely involved with as a health district in conjunction with these different groups is going to be a communications initiatives, including a campaign. And so planning is underway for that. But at this point, we've been working on having these different representatives from these community wellness prevention initiatives join us on radio segments that we already have available through the health district. So we're wanting to expand those to make sure that they're available both in English and in Spanish. Any questions on that?
I just had a comment. I just attended an opioid congress in Phoenix this past week, and one of their campaigns is that they had a mother, and it was statewide, tell her story. She said she was at work. All of a sudden, she got a phone call from a relative or somebody, and there was this huge snap of this kid passed out. And later to find out, they thought it was a joke at first, but he had passed, because he had taken fentanyl. And so I guess it was pretty impactful for the state.
Oh, yeah, I'd love to learn about that. Yes, because I think those are, to your point, it's important to have community-wide messaging in tandem with this youth-led messaging that we're wanting to focus on prevention as well. But absolutely happy to learn more about that as examples. Thank you.
Is there any more to your report?
I'll leave it at that. If anyone has any further questions, I'm happy to stay around.
So any questions? Thank you. If not, then we will move on. Next on the agenda is unfinished business, and this is the local DP organization.
Sure. Well, I'll go and read a summary of what the group drinking water warning is, and then afterwards, Sean and Kate are also here to elaborate on it and answer any questions you have before we get on to vote on the order. So The Yakima Health District is proposing the adoption of a local group B water system ordinance. This would allow the health district the authority to monitor for and approve treatment for group B systems that are affected by primary contaminants. With the local group B ordinance in place, the health district can review and approve the necessary treatment systems needed to ensure safe drinking water is being supplied to homes and businesses throughout Yakima County. This will also allow the health district to approve new group B systems that would otherwise be rejected during the development process. This will allow more land development projects to move forward and reduce negative impacts on property values for those served by the group B water system that has contaminants present.
Thank you. Do we have any questions or comments?
Yeah, I have some question about some of the language under section 6. And I'm just wondering if we should have language in there, just reiterating the constitutional process of access to private property. If you're in compliance with something.
Yeah, great question. In the development process for group B water systems, there is requirements, that they have easements, for rights of access in place. And that allows users of the system, to access the system, the operator, or purveyor management entity to enter the property to access the system, and as well as regulatory to access. So those easements are typically in place and filed on the titles of the property that water system.
And so do the easements supersede the constitutional process then? They bypass the Fourth Amendment?
Well, they've been established so that it creates the organizational authority to go in and handle this, yeah. So it's not a constitutional taking in terms of removing property from ownership, it's more access being granted.
Sean, do you mind reviewing what a group B is and the process and why it's a group system as opposed to an individual well?
Yeah, so it is typically a group B system is served by a single water source, the well. And there is a distribution system built in off that well, and it typically, in a residential setting, serves 3 to 9 connections. So to keep it simple, say 3 to 9 properties with houses on. So that well is serving, 3 to 9 households and the families that reside in those households. And if that water source, becomes contaminated with something, it's 3 to 9 houses that are also being contaminated, their drinking water is contaminated. But it is typically that source is on, a single parcel, and there needs the review process. We look at the design workbook of the construction of the well, the distribution system, what covenants are established so that no construction takes place within a certain distance of that well, no building or development, no hazardous chemicals, traffic, all that stays, a minimum 100 feet away from that well. It's called the sanitary control area. Septic systems, all that has to be free and clear of any potential source of contaminant. With that, the group B is typically, in a lot of cases, required to have what's called a SMA or satellite management agency. So that is the individual or the company that goes out and does maintenance on the system. Does maintenance on, it could be the pump, it could be the pressure tanks, it could be the switches that wear out over time, control boards, all that. And then also take water samples when necessary. And submit those to a laboratory. So they manage and operate the system, whereas the users typically fund it through a HOA or some sort of an association. Yeah, and that is all set up in the design workbook, and included in that is the requirement for easements to be filed on the title of the property that is that well is on. And that allows regulators and managers and any user of the system access to that well.
So does this so then this is just an absolute countywide, no matter, so anything that fits that definition, so say 4 lots of homes that are fed by a single well,
That well would
Is
be required to be.
automatically they're, required to have an easement and.
If they're required
access.
to have a group B, and that all depends on the zoning requirements through the planning department at Yakima County. But in a lot of cases, where people are developing these, a 4-lot subdivision, yeah, group B would be a requirement as for the water system to serve that development. And in that would be the requirement for the easements and covenants and, any group B that's being developed, there's always a initial water sample to make sure that that water source is clean.
So then what does that look like if, so it says the health officer may enter upon public and private premises at reasonable times for the purpose of conducting a sanitary survey and enforcing this rule, what does that look like?
Yeah, so when you're talking about private, that is typically the well that resides on a parcel that somebody owns, and that's where the easements are required. Public would be, if it's we have some parks that are served by Group B water systems, or other venues that have little enough traffic that they're not required to have a large Group A system regulated by the state. Yeah, that typically we're talking private, it's serving residential. Public, it's serving more on a commercial capacity.
Right, so how would the health, what would happen if he said, okay, I need to go do this? Is there notification? Is there? a
Yeah,
warrant,
we-
like an
yeah, our-
administrative warrant that's obtained?
No, typically we send notification in all of our programs. If we have to go investigate something, we send letters to the owners of the property, the owner of the in this case, system that we need to look at. We would notify the satellite management agency and identify what it is specifically what we need to deal with. So in terms of, let's say, a primary contaminant showing up in a well, let's say Usila, for example, we have PFAS. We know that that's an area of concern. We have Group B systems in there that have tested positive for PFAS above, state action level and federal limits. This would allow us to review and approve treatment systems to be installed on those water systems to give those folks clean water. Otherwise, without this, there is no provisions in the regulation that allow anyone to approve treatment systems for Group Bs. So they would effectively have to drill. And a symptom of that would be they cannot use that well anymore. They would have to drill.
So what was the prior process? So say, like, I used to live in that situation. There were 4 lots. We all shared a well. And we just did our own testing every year. We'd take a sample just to check, make sure that our well was okay. So if we had found something, what would we have done?
Without this ordinance, there's not really anything that could be
So, like,
done
we-
outside of decommissioning that well and drilling a new one.
So we couldn't have just said, oh, our well.
We're gonna
needs-
chlorinate the system. No, it wouldn't be allowed by regulation. By state regulation.
So Ms. Ackerman, this is really a response, not in terms of government wanting to create ordinances. It's the reality that we have an issue with a contaminant. We have a PFAS problem, and our concern is not just the immediate health and welfare of the individuals on wells that are contaminated, but it's the reality that without an ordinance that allows for these systems to address the contaminant, you won't have development in certain areas of the county because you won't be able to allow those wells to be created. So you literally could have a situation where someone owns property. They look to see if the well is an appropriate well, it's contaminated, they won't be able to develop that land. So we are really concerned not only for immediate health and welfare, but also long-term development in the county. And this Group B, if you want to show it, allows us to create address the problems so that people remain safe, but also property can be developed.
And we also had the same concern that you did on that section on enforcement, and we talked to our attorney to make sure that that was accurate. But we also would not go on a property without contacting the purveyor and the property owner for the safety of our own staff, making sure we're not going on private property.
And that's a universal practice. We always contact and notify. We don't ever just enter a property unannounced and say, we're here to do this. We notify and we identify the problem
Right.
we're looking at. And if someone says you can't access my property, then the situation changes and we have to approach it differently.
Yeah, really the focus on section 1 is sort of some of the initial communications, requests for information, sort of trying to work with. And then if you need to take an additional step at some point for public safety, that's when we sort of move into this next role of saying, hey, we write, we say, can we get together? Are we able to come and do this and review it? If we get to the point where the person's saying no, and it's causing potential harm for the area, I mean, the public health officer needs to step in and help. So we're kind of a last resort trying to get to this point, but really when it's needed, there aren't other options. So
Yeah, and in that situation, we're looking at it, well, this isn't a well, it may be serving the house that well's, the property that well is on. And that individual who may be trying to deny access, but also that's affecting the health of several other families that are also utilizing that well, and everybody has a right to clean drinking water, and how can we help that system provide clean water?
Right, yeah, it's just that there's this, progression towards government overreach and control of property, and especially through water issues. And I mean, like I said, my situation was, so wouldn't it be better to look at the regulations, like, which should be local for those kind of things of a homeowner, like, we're not gonna want, us four that were on that well, we're not gonna want bad drinking water, so we're gonna take care of it. We want clean, and we should have the right to do that. That should be the key issue. And giving up our freedoms for safety, I think as one of the founders said, really makes us deserve neither.
So how many wells are in Yakima County that are Group B? Do you have a number?
I believe it's over 700.
Yes.
Now, this ordinance is not for us to go and make contact with.
No, right, no, I understand that. I was just asking how large the problem is, like how
Yeah.
many are there?
Right, I think right now, there's 5 in the PFAS area.
Yeah, so this ordinance would be specifically looking at the Group B systems with a primary contaminant, which is one that has a direct risk for public health. So if it's iron or manganese, color, turbidity, those are all things that we can approve treatment for without this ordinance. But for anything like coliform, nitrate, PFAS, that's not allowed under the WAC. So we need to create additional provisions. So we currently have 0 Group B systems with a primary contaminant that's being treated. We have over 700 Group B systems without primary contaminant treatment. And the reason that the WAC doesn't allow for that primary contaminant treatment is that it doesn't have any requirements for ongoing monitoring, and it doesn't give local health the provisions to require ongoing tests to make sure that the treatment system is functioning properly and protecting the health and safety of the residents.
And I would just add too, that these are forever chemicals that we're talking about, so the accumulation of them in your system is not good. And so, I'm not medically inclined to speak for that, Barb or Melissa can, but the reality is that, we have an issue because of the detection near the drain center. And we're also finding that there are detections in other parts, and we're finding throughout the country that there's a detection of these forever chemicals in water systems. And so this is a big change that's going to happen if you want to speak to the change that's happening at the federal level with the state, but the numbers are very concerning.
Yeah, so currently the federal limit for PFAS in drinking water is 70 parts per trillion. The EPA is working to adopt a reduction in that maximum contaminant level down to 4 parts per trillion. And that's basically because all the PFAS testing available today, that's the lowest amount they can detect for accurately. And the state will be following suit and adopting the action level to mirror EPA, and PFAS will be recognized as also a primary contaminant. So the goal here is that the Army is providing point of entry treatment systems for wells affected by PFAS. Currently over the current federal limit, they will be working retroactively once the EPA adopts these new levels to go back through and getting point of entry systems on wells that are below 70 parts per trillion, and above 4. we have a number of group Bs that are affected by PFAS right now. The Army is gearing up to install point of entry systems on these group B systems. And not only that, they're rebuilding the entire system. Outside of drilling the well, it's gonna be all new piping, all new pumps, all new control mechanisms. It's, you know, really gonna be a system upgrade of sorts. But as of right now, if they installed those I'll call them POET for short, systems on those group Bs, we would effectively have to tell those homeowners, or those system owners, that that's not allowed by regulation, you have to shut it down. And telling people you can't drink the now clean water that you're being served with because it's not allowed in the state regulation, that's a tough place to be in too. With this local ordinance, it gives us the ability to approve those and, you know, move forward with clean drinking water. Additional benefits that we're looking at with this is areas that are not being developed because they're in areas with high nitrates and in areas with PFAS, and someone wants to invest in development of a property, they gotta sink $50,000 to $100,000 initially just to drill the well and get a pump installed and then take a sample of that water. And it comes back with a primary contaminant, the project's dead. With this, we can say, okay, we have a primary contaminant, there's an adequate treatment system to utilize here. The developer can plan for that and install that and then continue with the development of the project. And other existing group B, landowners that are served by a group B, if a primary contaminant shows up in their drinking water, one way or another, and we have the ability to work with that system and getting a treatment system that's adequate installed and set up a monitoring schedule to make sure that treatment system is effective and maintained by the SMA. We are removing that risk of massive property value reductions. You know, we're gonna preserve property values for folks that might be relying on that property as a long-term investment for retirement or for kids or families, whatever, what have you, so.
Thank you, Chair Myers. I appreciate the comments and the dialogue here. It seems like this revision of this this ordinance pretty necessary to avoid literally shutting down new growth in some of these areas that will be affected by the PFAS. And what we're seeing, and I don't know, Dr. Barg, if you want to speak to that or anybody else, but my understanding is that we originally had this thought of that PFAS plume. They're just kind of gradually moving kind of southwest from the area, but we've seen some tests in other areas where it's showing up in other parts of the county, like Terrace Heights, for example, where it's actually gone in areas that weren't anticipated, and they may not be at, you know, red flag amounts yet, or you know, but it's spreading. I know that from the Yakima County's perspective, we have several Group B systems that we manage and operate. So when this came out, I actually took the opportunity to talk to some of our water experts within Whatcom County. That's where I was born. And Sean McGee was kind enough to come in so we could review the ordinance together, bring to light some of the concerns that the county might have had about the ordinance. Felt good, largely they felt good about what they saw, had a couple suggested tweaks to it, which were accommodated. And so we appreciate that. And based on that action, we feel comfortable with what's being put in place, what's being proposed.
I guess my question, Sean, more lies in the fact that if the Army decides to do one thing and the budgets that they have to do that are, you know, effectively limitless, and then you enforce those rules on mom and pop 5 houses, they don't have a budget like the Army, and therefore my concern would be if we're making a rule that says everybody has to come into compliance with what this group did, and we make that across the board. I mean, that seems like it would be, and you're not grandfathering in the old ones that don't have these systems in place or that aren't even aware of a contaminant being there or not. My concern is if we pass an ordinance that says you have to come to this standard, period, and we don't care what the cost is involved in that, it seems that you're favoring one set of players that could come into compliance against another set that might not be able to, and that doesn't seem inherently fair to the individual property owners or the well operators that are tiny. And I would imagine in your 700, there's probably a lot that are tiny. And so this is my concern. I guess one solution for governmental entities that are going to fix the problem would be a very high standard, whereas another solution for private property owners that are 4 or 5 people getting together, it seems to me that should be a different standard. Could you comment on that?
Yeah, and yeah, that is something we're looking at. And again, this isn't gonna be spread across the county, say, hey, you have a new set of rules to follow. You have to submit a monitoring schedule to the health district to all 700 group Bs. This is simply gonna be the ordinance and which gets exercised for group Bs that come up with primary contaminants. Existing group Bs now aren't necessarily at risk, high risk to obtain a primary contaminant in one way or another, but if they did, this would be a process in which they could get treatment. And of course, you know, the financial burden of that is always going to be an issue, and that's something we want to explore, what resources are available out there. I know through the state DOH moving from a joint plan of responsibility, which is what we currently are, into having a local ordinance. There's potential for increase of funding and grants to help develop a program and assist systems in the treatment, getting treatment systems in place. Also, there's education and outreach efforts that could be done, and having systems to get educated, these associations get educated, and planning operations and maintenance. A lot of them pay dues into an account. Maybe a certain percentage of that needs to be dedicated to a potential treatment system in the future. So over time, they're building funds to accommodate a potential need for that down the road. But certainly we approach all these issues in an education and outreach capacity and try to be a resource before having to, ever engage in enforcement activity. Really, the only time we enter that, like, you will do this enforcement capacity is when someone doesn't even entertain the idea of wanting to explore an intervention or mitigation to eliminate a risk of a health threat to a community, whether it's hundreds of people or 5. So our goal is to educate and bring resources to the issue versus, providing or implementing a roadblock financially to these systems.
I guess it would be my suggestion that if we know the contaminators, we should maybe have them set aside funds for future contamination discoveries to be put toward that end. This is the base funds that you're going to use, some sort of, whatever it is, a trust or whatever. Like you see all these mesothelioma types where they set aside funds for, we know there's a problem and it's going to keep springing up. Let's set aside funds to address that. I think that that is an important thing that we should be discussing. And then furthermore, at least I didn't see in here, is there a grandfathering clause that would allow those that are currently in existence an exemption or at least a period of time to become compliant if it's discovered in the future that they are in fact contaminated?
Well, yeah, I don't know if there's, grandfathering doesn't really exist in the realm of public health, certainly not in environmental health. But yeah, if there was a primary contaminant discovered on a Group B residential system, it's small system, funding is an issue. It wouldn't be a turn your water off right now. It would be a, can we give bottled drinking water provided in the interim? Don't drink it, don't cook with it, you're showering and bathing in it, okay? And then let's explore, the most effective treatment at the most effective cost. And, it's not gonna be a, day 1 contaminants found, day 2 water shut off. It's gonna be a conversation and a planning on how to get that system in compliance, or, as I like to say, being able to provide safe drinking water. And keep in mind,
depending on the distance between one group B and another group B, if there's an ongoing source of contamination, let's say a septic tank that's leaking and it's coming into the groundwater, that's going to flow outside of that one group B into another area where another group B is. So it can keep going down the line unless the source is fixed.
I had not to share, but Commissioner Curtis had.
Yeah, just really quick. I know we're spending a lot of time on this, but I swear we had a few health district meetings before where we talked about this, and I understood it that on this contaminant list, the authority, the entity that controls that contaminant list is our State Department of Health. We don't control it. So what we're worried about is as time goes on, newer contaminants are likely going to be added where we're threatening local B water systems that the state is claiming is a contaminant and of issue, but the state is not going to prescribe any subscriptions. So what this is doing is allowing us, in the event new stuff gets added, to actually ensure that this water system is able to continue to operate. And that's why I see this vital component. I agree. It seems redundant to me that we need to get to this point, but it is a major oversight in the WACs and just how this system and compliance was set up. So is that correct in the compliant list that we don't have authority over that not compliant list?
Primary contaminant list.
Contaminant list, yeah.
And that list is updated and adopted by the State Board of Health. It's presented to them by DOH, and the State Board of Health adopts that, much like we're attempting to adopt this. So, yeah, and it gives us, it does keep that authority of how we address these new issues local and how we respond to them local. And certainly, you know, we would explore resources that could be provided by the state, but the state wouldn't have any decision-making authority in this. We may utilize some expertise on how adequate or effective certain treatment systems are, but it would ultimately be us approving.
And I wanted to share to your concern about the immediacy of having to install one of these. One of the reasons that we've spent so much time this year, and again, my compliments to our team working collectively in environmental health and community partnerships, is providing filtration and water, direct water to people, because we were so concerned with both nitrates and PFAS that people didn't have adequate drinking water sources. So that's our first and primary concern. What you're bringing up about the cost, and sometimes for people who are on modest incomes, the serious cost of these systems, it is a concern. But we are also going to be having to discuss as a board in the future, the fact that we are dependent in a lot of this county and in some of our cities on septic systems that are very old, and some of those properties cannot allow for another septic system. And when you're talking about growth of cities, if you have an existing system, you can use it, but if it fails and you're near a municipal system, you're supposed to get on that sewer system. And the cost to get on those systems can be very high. Can be from, $1,000, $1,200, $2,500, $3,500. Many people can't afford that. And we don't want people to use a failing septic system. We don't want people to break the law, but the reality is that having some sort of revolving fund or opportunity to make payments on it is something I'd be very much interested in exploring, because we often have that with utility systems in large communities where you have an upgrade to your system and you pay a small fee for the privilege of having a lease essentially on that until you pay it off and it's yours. I'd like to explore that because going back 5-6 years when Larry Matson was at the Yakima Valley Conference of Governments, we were talking about having a countywide plan for the reality that people are not going to be able to afford to maintain these systems. And as properties shrink in size, you're not going to be able to put a new septic system on that property. And so it's going to be a coming issue that we've actually been bringing, really elevating to the state level, because as you said, it's an unfunded mandate and it's a concern. So, but I think it's a long-term issue, but it's definitely a planning and urban development issue that we'd like to do. Did I share that?
Yeah, yeah, and I'll also add that, today's today, groundwater that provides drinking water to residents of Yakima County, that it's a dynamic situation. We have a lot of different issues going on and some promising funding sources that are entering these issues all the time. So there's opportunities to explore the different resources that we could utilize for something like this. certainly we're utilizing those funds for other initiatives too that are more of long-term solutions, but this gives us a very effective response tool to situations that otherwise would become much more expensive. You know, if, for example, if a water system required a treatment system that would cost $10,000, let's throw it out there. I mean, not all treatment systems cost that much, but say it needs to be rather robust. That's still a lot more cost effective than having to spend a couple $100,000 creating a new Group B water system. A new water source that you gotta drill that well, you gotta install the pump. You may have to redo distribution lines, potentially a new well house, new pressure tanks, depending on what the contaminant is, but that also is a new design review workbook, new engineering, you know, it's new covenants, new easements. So that would be the requirement today under our joint plan of responsibility. Contaminated well, need a new one. This could save a lot of money for water system users, if you want to look at it strictly from a cost perspective.
Well, I want to commend the health department on, and the health district, I should say, on the foresight to look into this, because if you look around Yakima County, obviously, we're a very dynamic, water dependent area. And not that anybody isn't water dependent, that's a silly statement, but I mean, agriculture, dairy, city planning, growing communities, they're all going on all around us. And so the decisions that we make here will have widespread impacts to our community. And I think we should be in the forefront of the decision-making, or at least guiding the decision-making for our communities, because it's such a critical problem. And I think as time goes by, that problem is going to grow. These lists are going to grow. The contaminants are going to be found. And there's not enough clean water. And so we need to do everything we can to protect that resource for all aspects of our community.
Any other comments or questions to add to the discussion at this point? But this is an action item, which means that we would entertain a motion to pass the ordinance.
So, Madam Mayor, I'll move that we adopt local Group B public drinking water ordinance.
I'll second. Thank you. We have a motion and a second to adopt, or in this case, to pass the local Group B public drinking water ordinance. And we'll do a roll call on this, please.
Okay, if you're in favor of the motion, please state yes. If not, please state no. Commissioner Lindy?
Yes.
I believe Commissioner McKinney, are you still there?
I don't believe she.
Okay, Stephanie?
Yes.
Lee?
No.
Lupita?
Yes.
Dr. Atterbury?
Yes.
Commissioner Curtis?
Yes.
No. Catherine?
Yes.
And Mayor Byers?
So the ordinance passes. 7-1. Thank you. And I really appreciate your questions. We appreciate everyone's comments and questions. It's a very robust conversation. Those are the few things that come here about very important. Thank you to the board. All right, we're going to move on to new business under item 9. The first is the solid waste ordinance.
Okay, again, I'll go ahead and read a summary of this ordinance, and then if there's any questions or input from our faith, then we can have that. Every fiscal biennium, the Yakima Health District receives funding through an agreement with the Washington State Department of Ecology to aid in the Yakima Health District regulatory duty with the solid waste program. One requirement of the agreement is that the health district must adopt a local ordinance for the Yakima Health District solid waste program. The approval of the ordinance would officially allow Yakima Health District to adopt and regulate under the solid waste regulations outlined in both the revised Code of Washington, RCW, and the Washington Administrative Code. Yakima Health District uses the state RCW's WACs as its regulations for our local solid waste facility. The adoption of this ordinance will not change the way solid waste facilities are regulated, will meet the requirement of the agreement, and secure the funding for this program. So basically, it's something, what we've done is for decades, we've followed the state regulations. And so now the State Department of Ecology is saying we need to adopt, officially, formally adopt those statutes or those regulations that we use or have our own local ordinance. So what we're proposing in this ordinance that we continue like we have been in the state regulations.
Any questions or discussion?
It sounds to me like we're just being required to codify what we've been doing all along.
Yes.
And also, in order to receive the two-year-long grant, we have to have something that
Yeah.
says.
And we renew this grant every 2 years, and it's a significant amount of funding for our solid waste program, which over the last few years has been very valuable to some of the work we've been doing.
Any other questions?
It is interesting to me, just under section 1, that we apply to all territory. You know, that's kind of an interesting word that you don't see thrown around.
Hearing no further discussion, I would entertain a motion to pass the ordinance.
Motion.
I'll second.
So we have a motion and a second to pass the ordinance as read. We'll just do this by show here. All of those in favor, please say aye.
I,
Do you have any opposed? The motion passes 8-0. Thank you. And now I'm going to turn the next two items over to Mr. Arbach to read on this because we're going to be electing the chair of the board and the vice chair of the board.
Okay, so every year in January, the school act require that, well, the first meeting of the year that we elect a new board chair and vice chair. And so at this time, we can do that, and so we'll open up the nominations if anyone wants to nominate the board chair.
I would nominate Patricia Byers to continue in her role as chairman.
I'll second.
Patricia Byers.
I'll accept the nomination. Thank you.
Any other nominations?
So in that case, we'll take just a show of hands vote. All of those in favor of appointing me as chair of the board again, please say aye.
Aye.
Any opposed? Nobody opposed. Passes 8-0. Thank you.
Okay, and now next item is for the vice or the vice chair, and any nominations for vice chair.
I'd like to nominate Commissioner Lindy for vice chair.
Second.
Would you like to accept?
Oh, yes, I'm willing to accept. Thank you.
Any other nominations?
Well, seeing none, then we'll take a vote. All of those in favor of appointing Commissioner Lindy again to vice chair, please indicate with an eye.
Aye.
Any opposed? None. It's in the thing. Thank you, board, very much. I appreciate your confidence in both Commissioner Lindy and to continue to That is the end of our new business, unless somebody has other business to bring for the board today.
Just for maybe the health district staff for our next agenda, I would be curious on your guys' thoughts. I know Portland enacted a state of emergency for the fentanyl crisis, and they're using all sorts of resources, but I'd be curious after that, I think it's only for 2 weeks where they have that state emergent declaration of emergency, but did they accomplish anything in 2 weeks, I guess is what I would be curious to look at for us as, did they do anything that maybe we as a health district in the county should be looking at as far as a state of emergency for fentanyl overdoses?
I was not aware of that short period of time, so that's quite interesting. Normally you have a state of emergency until you've solved the emergency. I would hesitate to think that you could solve it in 2 weeks, but I will certainly look into that. We have colleagues in Clark County, which is right across from Portland, so I can meet with them, I can visit with them. I'd love to see what they're doing. I will share with you candidly that we have expected a state of emergency from the governor's office on this issue. It has not come. One of the reasons that we pushed so hard for Narcan distribution was because it didn't come from the state. The state doesn't have the resources available for some of this, which is again, as Lindley mentioned, there's this leave behind program where if you visit a home where there's a drug user, you can leave behind, but there's not actually a program for first responders to use. To me, that's unacceptable. That's why we've invested so heavily. But there is the potential for legislative support for Narcan distribution, I think to the tune of $1.3 million, which I think is low. So I would be very interested in that. And one of the questions is, does by issuing the emergency declaration, does it trigger federal or state support? So I'm happy to look into that. I think that's a wonderful idea.
Thank you, Commissioner Kyle Kirby. Any other new business? Desired agenda items? No? All right, then I'll entertain a motion to adjourn.
Motion. Second.
We have a motion and a second to adjourn into our next regular scheduled Board of Health meeting on February 28th, 2024. All those in favor, please say aye.
Aye.
Any opposed? Then we are adjourned. Thank you so very much.
Thank you.